Yes.
Hello.
Yes.
Okay, can you please start reading MCQ?
Okay. Which of the following is the most appropriate next step in management? A 65-year-old man with a 45-pack smoking history presents with progressive dyspnea and chronic productive cough for 3 years. He reports frequent winter bronchitis episodes. On exam, he has a barrel-shaped chest. Okay, use of accessory muscles are present and diffuse wheezes. ABG on room air shows pH, okay, it is acidosis, PaCO2 is 56, PaO2 is 54, and bicarb is 30. Okay. He is on inhaled tiotropium and salbutamol. Today's SpO2 is 88 at rest. Okay, which of the following is the most appropriate next step in management? Okay, start high flow oxygen by non-rebreather mask. Initiate long-term home oxygen therapy. Add inhaled steroid and LABA combination. Schedule pulmonary rehab after ABG normalization and start oral prednisone. Taper for 10 days. Um, um, so I don't want to like okay. So he's already on beta blocker and tiotropium. And also the patient is okay, maybe I will just do home oxygen. I'm not sure. I would just choose option B.
Okay, so you want to pick option B.
Yes.
What about others?
Yeah, I will go with B because if you have like 88% of oxygen SpO2, that's the criteria. If you have less than 88 or equal to 88, and then I think O2 of 55, you have to start the long-term oxygen. I'll go with B too.
Okay. And what's your answer? What about you?
Yes. Also, I choose B.
Okay. So let's go into the details. If we look at the scenario, they have mentioned that patient is having the patient having a history of 45 pack year smoking with progressive dyspnea and chronic productive cough for 3 years. So chronic, there is chronic carbon dioxide retention. There is hypoxemia, oxygen level less than 55. And then there is a compensatory respiratory acidosis. So this patient is basically having a stable, severe COPD, because when we look at the different parameters, having chronic carbon dioxide retention, hypoxemia, which is oxygen level less than 55, compensated respiratory acidosis. So now let's talk about what is the most appropriate next step in the management. The option A is start high flow oxygen by non-rebreather mask. Basically, if you give a high flow oxygen at this stage, it can suppress hypoxic respiratory drive. Particularly in chronic carbon dioxide retainers, and that can lead to acute carbon dioxide narcosis and acidosis. So that's why in these patients you are going to give oxygen, but your oxygen should be low flow. The target is to give oxygen or the flow of oxygen should be 88 to 92. So instead of high flow oxygen, we will prefer a low flow oxygen for this patient, because if we give a high flow oxygen, it can suppress the hypoxic respiratory drive in chronic carbon dioxide retainers. Clear?
Okay.
Then we have the option C, which is giving an inhaled corticosteroid and long acting beta agonist combination. This option will be the correct option in case of frequent exacerbation. So this is indicated only in frequent exacerbations despite giving long-acting muscarinic agonist or in overlap with the asthma features. So over here, it does not address the resting hypoxemia of the patient. The option D is to schedule a pulmonary rehabilitation after ABG normalization. This could be a great add-on option or a great adjunct option because it will increase the exercise capacity, but it could be a great add-on or adjunct, but it is not the first line life-saving measure when hypoxemia criteria is present like in this patient. Clear?
I have a question. When you say pulmonary rehab, is it like spirometer use?
In pulmonary rehabilitation, basically, it's a full program in which we guide the patients regarding the exercise, education, and lifestyle program. Our goal is basically to improve the functional capacity, symptoms, and quality of life of the patient with any chronic lung diseases, like especially moderate to severe COPD. It's kind of a multidisciplinary program that include exercise training, particularly focusing on endurance and strength. It includes some breath techniques as well, breathing techniques as well, like pursed lip or diaphragmatic techniques. It it also have this option of nutritional counseling, psychological support, and patient education, guiding the patient regarding inhaler use, pacing, or exacerbation prevention. So it's a full plan or full program that is basically used to improve the quality of life of a patient with a chronic lung disease.
Okay.
The last option we have is to start oral prednisone and taper for 10 days. Again, it could be the correct option. It is used for acute exacerbation, not for the stable cases of COPD. And if you put the patient on oral steroids for a very long period of time, or long-term oral steroid therapy will also increase the risk of mortality or increase the mortality in patients. So oral prednisolone will not be a correct option over here. So technically we are left with option C, which is to add inhale. We are left with option B, which is to initiate a long-term home oxygen therapy. Basically, when we say long-term oxygen therapy, what are the indications of long-term oxygen therapy? The indications of long-term oxygen therapy is if the resting PaO2 is less than 55 mmHg or SpO2 is less than or equal to 88%, or pressure of oxygen is less than or equal to 59 mmHg, or SpO2 is less than or equal to 89%. With core pulmonale, right heart failure symptoms, or hematocrit above 55%. So what are the indications for long-term oxygen therapy? If the resting pressure of oxygen is less than or equal to 55, SpO2 is less than or equal to 88%, pressure of oxygen is less than, or if pressure of oxygen is less than or equal to 59, with SpO2 less than or equal to 89, but with pulmonale heart failure or hematocrit more than 55%. Then we have to put patient on long-term oxygen therapy, because in these patients long-term oxygen therapy will improve the survival, quality of life, exercise tolerance, and pulmonary hypertension. Clear? This is clear to all of you?
Okay.
It's clear, but like, for how long the duration would be of using the long term, like daily?
Can you please repeat the question? I didn't hear you properly. I can't hear you properly.
Yeah, like how long daily usage of long-term oxygen therapy is like recommended for?
Long-term oxygen therapy is recommended until you get back to the normal parameters.
Oh,
And if you like it should be continue until you get back to the um, normal parameters. But if you are asking me about the duration, so at least it should be given for above 15 hours per day to see a significant improvement in the survival and quality of the life. And ideally it should be used continuously throughout 24 hours per day except during bathing to maximize the benefits. And your parameters should be reassessed after 60 to 90 days to ensure that are you really need to continue this, or you can easily stop this. So you keep on reassessing the parameters every 60 to 90 days to look for the need. If the parameters go back to the normal value, you can stop the long term oxygen therapy. Clear?
Yeah, clear.
Now let's talk about COPD. COPD is basically a chronic progressive, largely or mostly irreversible airflow limitation or airflow obstruction, which could be due to chronic bronchitis or emphysema. So, what is COPD? COPD is a chronic, progressive, largely irreversible airflow limitation due to chronic bronchitis and emphysema. What is the definition of chronic bronchitis? If there is a productive cough for 3 or more than 3 months per year for 2 consecutive years. And what is emphysema? It's a destruction of alveolar walls, loss of elastic recoil leading to air trapping. What is important for exam? You should have an idea about the pathogenesis. Cigarette smoking lead to neutrophil inflammation, and protease level is high as compared to antiprotease, so it will lead to a protease antiprotease imbalance that will cause the destruction, eventually leading to COPD. Plus, another point will be during COPD lead to increase elastase activity, decrease alpha 1 antitrypsin, and alveolar septal destruction. These are your basic step 1 points. So, what are the different pathogenesis pathogenesis important points you need to remember regarding COPD? First, the main culprit or the main risk factor is cigarette smoking, that can lead to neutrophilic inflammation and protease antiprotease imbalance. It increases the elastase activity, decreases the alpha 1 antitrypsin activity, and causes the alveolar septal destruction. So basically, there will be a collapse of small airway during expiration, and air get trapped, and patients start hyperventilating. Sorry, the air get trapped, and it leads to hyperinflation. Clear?
Yes,
When it comes to COPD, it has two phenotypes. Chronic bronchitis and emphysema. The main difference between the chronic bronchitis and emphysema are, in case of chronic bronchitis or blue blotters, the main pathology is mucus gland hypertrophy plus goblet cell metaplasia. When we look at the VQ ratio, there is decrease in the VQ of ventilation perfusion mismatch. There is a ventilation perfusion mismatch, and you can decreased PQ that can lead to severe hypoxemia plus hypercapnia. When you look at the patient appearance wise, your patient is cyanotic, overweight, and you can also see edema. DLCO is normal in these patients, and when it comes to the prognosis, chronic bronchitis patient can go into cor pulmonale. While with the emphysema or the pink puffers, the main problem is alveolar wall destruction. You can have mild decrease in VQ that can lead to near normal pressure of oxygen, carbon dioxide, sorry. So, when you look at the ventilation perfusion, for chronic bronchitis, there is a severe decrease in a VQ that can lead to hypoxemia and hypercapnia, while for emphysema, there is a mild decrease in VQ that can lead to near normal level of carbon dioxide. When you look at the appearance, you can see a thin barrel chested man. When you look at the DLCO, diffusion capacity of carbon monoxide, it is going to be decreased because now the problem is with the alveolar wall, so the diffusion will be compromised. When it comes to the prognosis, emphysema or pink puffers can develop late cachexia. Clear?
Okay.
Then let's talk about the clinical presentation. Clinically, the patient is going to present to you with chronic cough, with sputum with dyspnea on exertion, prolonged expiration, wheeze, barrel-shaped chest, pursed lip breathing, accessory muscle use, tripod position, decreased breath sounds, and then you can also have signs of cor pulmonale like JVD, edema, and loud P2. Clear?
Could you repeat that?
Yes, I'll repeat. Chronic cough with sputum and dyspnea on exertion, prolonged expiration and wheeze, barrel-shaped chest with a pursed lip breathing in case of emphysema, accessory muscle use, tripod position, decreased breath sounds, and signs of cor pulmonale like JVD, edema, and loud P2.
Okay.
Now let's discuss the investigations, which is important for step 2. You can do spirometry, which is the gold standard. If they ask you the best test or a gold standard, the answer will be spirometry. What are the findings when you do the spirometry that give you a clue for COPD? Your FEV1 is decreased. FEV1 over FVC is decreased, usually less than 0.7. Post bronchodilator, residual volume is increased and TLC is increased because of the air being trapped inside the lungs. These would be the spirometry findings that support COPD diagnosis, and the gold standard investigation is spirometry. The other thing that you can do is irreversible obstruction even after the bronchodilator test. That is also a part of the spirometry. The second test you can do is ABG pattern. When you look at the ABGs, you should have an idea how you can pick that it's a chronic retention or it's an acute exacerbation. In case of chronic retention, the pH is normal or sometimes slightly low. Carbon dioxide is going to be obviously high. Bicarb is also going to high, that represents the compensation. But if it's an acute exacerbation, the pH is going to be low. Carbon dioxide is going to be increased rapidly. Clear?
Okay.
The third thing you can do is chest X-ray. So what could be the chest X-ray findings? You can have flattened diaphragm, you can have hyperinflated lungs, you can have decreased vascular markings, you can see bullae in the upper lobes. Then you look at the DLCO. It is decreased in emphysema while normal in chronic bronchitis, which we have discussed already. You can also do CBC. There might be a presence of polycythemia if it's a chronic hypoxemia. So after investigations, the next step will be management. Again, something you need to know for exam. Step 2. Management is divided into, okay, we'll talk about that. Um, let's suppose you have a stable patient or you have a stable case of COPD. How you can manage this patient? The first step will be smoking cessation. It has the most effective mortality benefit. You can give the vaccines, particularly influenza vaccine annually and pneumococcal vaccine. Among the pneumococcal vaccine, PCV20 with or without PPSV23 is recommended. But among the vaccines, influenza vaccine annually and pneumococcal vaccine should be given to the COPD patient. Then bronchodilators. You will start with short-acting beta agonist. You can shift to long-acting muscarinic antagonist. Then you can shift to long-acting beta agonist with or without inhaled corticosteroids, depending on the stage. So this is how the bronchodilator, you upgrade the bronchodilator depending upon the need. Then you do the pulmonary rehab. To increase exercise tolerance and decrease the dyspnea, we have oxygen therapy option. You put the patient on long-term oxygen therapy if oxygen is less than or equal to 55 or SpO2 is less than or equal to 88%. And the last option is surgery. If nothing works, then you can go for the lung volume reduction by doing the surgery, or you pick the option of lung transplant, but lung transplant could be done only for the selected cases. Clear?
Okay.
This is clear to all of you? Hello?
Yes.
Clear.
But on the other hand, if you have a patient with acute exacerbation of COPD, that it could the patient, they might have mentioned some trigger like infection, it could be bacterial or viral. They might have mentioned some pollution related thing or non adherence to the medicine or inhaler. So they usually are going to mention some trigger that lead to the acute exacerbation. And what is the treatment for acute exacerbation? You'll start with the oxygen therapy. And the target is to keep SpO2 between 88 to 92%, like on a low flow oxygen therapy. Then you will give bronchodilators. You start with short acting beta agonist with or without short acting muscarinic antagonist, nebulizer for 20 minutes, 3 times a day. Then we have the option of systemic steroids like prednisone 40 mg per oral for 5 to 10 days, or you can also give IV methylprednisone depending on the need. You can give antibiotics if there is an increased sputum volume or purulence or need for ventilation. You can put the patient on antibiotics like azithromycin, doxycycline, and levofloxacin. Then you have an option of non-invasive ventilation like BiPAP. It is usually recommended for respiratory acidosis. pH is less than 7.35 and pressure of carbon dioxide is more than 45. So that would be an indication for non-invasive or ventilation or BiPAP. Clear?
Okay.
And in the end, you have an option of intubation. If BiPAP fails or if the patient's mental status decline, then you have the option of intubation. So what we have established up till now that we can manage a patient of COPD depending upon the status. If your patient is stable, it will be a different management. If your patient is in acute exacerbation, the management will be different. Now let's talk about the drug therapy. The drug classes which we have discussed. Sorry. Short acting beta agonist or long acting beta agonists like albuterol or salmeterol, they are bronchodilators. Then we have short acting muscarinic antagonist, long acting muscarinic antagonist. These are anticholinergic drugs. The examples are ipratropium, tiotropium, and their main purpose is to decrease the secretion. Then inhaled corticosteroids like fluticasone and budesonide. These drugs anti-inflammatory effect. So these are added if there is a frequent exacerbation. Then phosphodiesterase 4 inhibitor like uh, roflumilast. It simply reduces the exacerbation in a chronic bronchitis patient. Clear?
Yes.
Yeah.
Then we have the long-term oxygen therapy, which we have discussed already. For long-term oxygen therapy, the indications are important. Classically given in the U world, oxygen pressure of oxygen less than or equal to 55, or SO2 less than or equal to 88%, or pressure of oxygen less than or equal to 59 mmHg, or SO2 less than or equal to 89% with carpulmonale or polycythemia. The benefit of long-term oxygen therapy is it will increase the survival, decrease the polycythemia. Then there are certain complications associated with COPD, like acute exacerbation can lead to respiratory failure. Patient can develop pulmonary hypertension that can cause pulmonale. Patient can develop polycythemia, pneumothorax from ruptured bullae, weight loss or cachexia, secondary spontaneous pneumothorax, in which the patient can develop a sudden dyspnea in COPD patients. So these are the main complications. Now let's talk about the prognostic factors. This is important. The prognosis of COPD depends on FEV1. Decrease FEV1 will give you a prediction of the COPD outcome. Weight loss, development of pulmonale, and low oxygen when it is less than 55 mmHg. These are the prognostic factors for COPD. Clear?
Okay.
If they ask you about the prevention, which is again important, always remember the most important prevention strategy is smoking cessation. Smoking cessation is most important prevention strategy. Then we have vaccines like influenza and pneumococcal. You can avoid the pollutants and irritants. So the main points are COPD is a chronic progressive, largely irreversible airflow obstruction diagnosed by spirometry, managed by smoking cessation bronchodilator, vaccine, pulmonary rehab, and oxygen if patient is hypoxemic. You can treat the exacerbation aggressively and avoid oxygen overcorrection or high flow oxygen, and always target the pressure of oxygen between 88 to 92%. Clear?
Okay.
Okay, the few points
Okay.
you should have an idea about. Okay, tell me, if there is a patient chronic smoker but normal DLCO, what you should think about?
Chronic bronchitis.
Yes. If DLCO is decreased, then
That'll be emphysema.
yes. If there is carbon dioxide retention plus metabolic compensation, what will be the diagnosis?
Like this patient, stable COPD.
With chronic respiratory acidosis.
Okay. Uh, so that'll be COPD then.
Yes. There will be symptoms of COPD. Along with that, if they mention carbon dioxide retention and metabolic compensation, so it will be a chronic respiratory acidosis case.
Okay.
Beta blockers are safe for COPD patients, but you can give only cardio-selective beta blockers like metoprolol or bisoprolol. If a patient is having acute exacerbation of COPD, when you do the ABGs, you can see that pH is less than 7.35, carbon dioxide is more than 45. What is the best next step in the management?
Could you repeat that?
Acute exacerbation of COPD, pH is less than 7.35 and carbon dioxide pressure is above 45.
Should we initiate oxygen therapy?
You can initiate the bypass for
Yes, you should give the BiPAP. The next best step in the management will be BiPAP for this patient. For acute exacerbation plus pH less than 7.35, carbon dioxide above 45, start BPAP because now the patient is airways are already obstructed and carbon dioxide can't be exhaled, leading to hypercapnia. Patient is in respiratory acidosis. So BiPAP will help by decreasing the work of breathing, improving alveolar ventilation, and increasing the carbon dioxide clearance for this patient. What is the most effective intervention for survival in COPD patients?
Smoking cessation.
Very good. The answer will be smoking cessation. And if you have an option that contains smoking cessation plus long term oxygen therapy, you can pick that option as the best option. So, this is all about COPD. So, COPD is clear to all of you.
Yes. Also, Dr. Fatima, which notes should we refer to other than first aid? Is there something else would you recommend to go through
See,
the
I
notes?
didn't recommend any notes because I want you guys to focus primarily on UWorld information. Because when if because you guys are doing the UWorld alongside the classes, and UWorld is already it contains condensed, it's contains a lot of information, almost everything that you need to know for exam.
Okay.
So if you start doing any notes alongside, there are pretty good notes available. But if you start focusing on notes, your focus from UWorld will be distracted. You won't be able to focus on UWorld as it should be. So that's why I would simply say that focus on UWorld. Try to memorize the information from UWorld because that is your primary source for step 2.
Okay. Thank you.
Please read the slide.
Which of the following is the most appropriate next step in the management? 52-year-old man presents with daytime sleepiness, morning headaches, and poor concentration. His wife says he snores loudly and sometimes stops breathing during sleep. BP is 150 over 96. The BMI is 34. Exams show crowded oropharynx neck circumference. Polysomnography show multiple episodes of airway cessation with continued thoraco-abdominal effort. The choices are to start nocturnal oxygen therapy, begin oral acetazolamide at bedtime, recommend weight loss and start CPAP, prescribe zolpidem for better sleep, perform tracheostomy immediately. So this is like a case of obstructive sleep apnea as patient is obese. Um, so I might choose like option C.
Okay. So you recommend weight loss and start CPAP. What about others?
Yes, I think that's the correct answer. I'll choose C as well.
Me too.
Okay. So let's now understand the question. Which of the following is the most appropriate next step in the management? The first option was to start a nocturnal oxygen therapy. As this is a case of obstructive sleep apnea, starting oxygen therapy, obstructive sleep apnea is basically due to an airway collapse. So it is not like that the body doesn't have oxygen, but the airway lacks oxygen. The problem is that airway is collapsed. Oxygen does not correct the obstruction or prevent the apneas. So A is the incorrect option. The B is to begin oral acetazolamide at bedtime. It is used for central sleep apnea. Because when you give acetazolamide, it will decrease the respiratory drive and can help you to improve the symptoms associated with central sleep apnea. It is not recommended for obstructive type of sleep apnea as in this patient. Clear? Because the BMI is so high, so this is a case of obstructive sleep apnea. Clear?
Okay.
The option D, which is to prescribe zolpidem for better sleep, it can even worsen the hypoventilation by depressing the airway tone. So this is not at all recommended. Then we have tracheostomy. It is reserved for the life-threatening refractory cases. When everything else fails, then you can have this option of performing tracheostomy. It's not a first line thing. So what is obstructive sleep apnea? Recurrent upper airway obstruction during sleep, leading to episodes of apnea that should last for more than 10 seconds without airflow, despite ongoing respiratory effort. The result is intermittent hypoxemia plus hypercapnia plus sleep fragmentation. We'll talk about the risk factors, or you can say categories. It can be associated with anatomical problems like BMI above 30 or obesity, large neck circumference, retroganthia, macroglossia, tonsillar hypertrophy. All of these can anatomically lead to obstruction. Then we have some demographic things like it is common in middle aged men and it is also common in post menopausal women. Then you have certain other options, risk factors like nasal obstruction, hypothyroidism, acromegaly, alcohol or sedative use before sleep. All of these can contribute to obstructive sleep apnea. What is the problem basically, or what is the pathogenesis? During sleep, your pharyngeal muscle tone is decreased. It can lead to airway collapse, repeated apneas leading to hypoxemia, plus hypercapnia leading to arousal and sympathetic surge. Leads to sleep fragmentation and can put stress on cardiovascular system. This is a basic pathology, risk factors, definition, which you have discussed already during your step 1 preparation. The clinical features are, we divide the clinical features into two categories. The clinical features that you observe during the daytime, and there are certain features that you are going to observe nighttime. Daytime symptoms are loud snoring, witnessed apnea, choking, gasping during sleep. Sorry, nighttime symptoms are loud snoring, witnessed apnea, choking, gasping during sleep, while daytime symptoms are excessive daytime sleepiness, poor concentration, morning headaches. It can lead to impotence and irritability. Nighttime symptoms are fatigue, dizziness, headache, irritability, So we were discussing the complications. Among the complications, systemic hypertension is the most common. The other complications are pulmonary hypertension, cor pulmonale, arrhythmias, insulin resistance, stroke, coronary artery disease, sudden death, secondary polycythemia. All of these could be the complications associated with obstructive sleep apnea. Now let's talk about the diagnosis. Gold standard is polysomnography. You do a polysomnography, which is a sleep study and gold standard for diagnosing a cases of obstructive sleep apnea. If by doing polysomnography, your hypoxia, sorry, apnea apnea index or AHI, if its value is 5 to 15 episodes per hour, this is a mild case. If it's 15 to 30 episodes per hour, it will be a moderate case. If it's above 30 episodes per hour, then it's a severe case. Clear?
Okay.
During the event, airflow stops but thoracoabdominal movement continue. It will help you to differentiate between obstructive sleep apnea from central sleep apnea. Now let's talk about management. When it comes to the management, the first line is weight reduction. Your goal is the BMI, weight reduction, specifically if BMI is above 25. The second thing you can go as a first line is continuous positive airway pressure, particularly at night to keep the airway patent. रोज मेरे साथ वाले कमरे से मेरा फोन ला के देना, मेरा फोन ला दो. So the first line is weight reduction, especially if BMI is above 25. Then you can give the patient CPAP at night to keep the airway patent. The alternative options are to avoid the alcohol, sedatives, and opioids. Sleep lateral, sorry, sleep in the lateral position, not the supine position. Oral mandibular device, oral mandibular advancement device. It is recommended for mild to moderate cases of obstructive sleep apnea, especially if they can't tolerate um, CPAP. You can also do the other options will be tonsillectomy. And the last option will be tracheostomy. Is a last resort for refractory, life-threatening obstructive sleep apnea. If they ask regarding pharmacological therapy, we have some non-curative options like giving stimulants, modafinil, वहाँ पे लगा दो, we have some non-stimulant options like modafinil. Modafinil basically this is the drug that may reduce residual sleepiness after adequate CPAP. So this is not curative in nature, but it's a stimulant and it can help with the residual sleepiness after adequate CPAP. Clear?
Okay.
Yeah.
So now let's talk about that how you can differentiate between obstructive sleep apnea and central sleep apnea.
Dr. Fatima, this is the same one you gave for narcolepsy?
Yes. So now let's see how you can differentiate between obstructive sleep apnea and central sleep apnea. When you look at the airway effort, in case of obstructive sleep apnea, it's present. While in case of central sleep apnea, airway effort or respiratory effort is absent, because now the problem is with the brain. The problem is with the respiratory center in the head, in the brain, so the respiratory drive is absent. The cause usually for obstructive sleep apnea is airway collapse, while for central it's decreased CNS drive, heart failure, stroke, opioids, or high altitude. The treatment is different for both. In case of obstructive sleep apnea, you are going to treat by weight reduction and CPAP. For central, you will treat the cause along with giving acetazolamide. So that majorly you should have an idea how to differentiate between the two so that you can pick the right treatment option. Clear?
Okay.
If you have a patient with a daytime sleepiness plus loud snoring, what will be your diagnosis?
OSA.
Yes, it is obstructive sleep apnea until proven otherwise. Always remember that the CPAP is the most effective therapy to decrease the daytime sleepiness, somnolence, decrease the blood pressure if patient is having hypertension, decrease the cardiovascular mortality. What is the gold standard test diagnostic test that can be used for sleep apneas?
Polysomnography.
Yes. What are the common complications associated with obstructive sleep apnea?
Cor pulmonale.
Systemic and pulmonary hypertension and polycythemias. Always
Okay.
remember, if your patient is having untreated obstructive sleep apnea for a longer period of time, it can lead to resistant hypertension and arrhythmias as well. Which drug can be used to reduce the residual sleepiness after giving CPAP?
Modafinil.
Our next topic of discussion is atelectasis. Um, before the next class, let's go through a topic of atelectasis, particularly absorptive atelectasis is something that they frequently test you on exam. So the next two topics which are important and we are going to discuss in our next class are atelectasis and respiratory distress syndrome or acute respiratory distress syndrome. Okay, next we have this algorithm regarding the treatment of menopause. Okay, so first of all, when we have the vasoactive vasomotor symptoms, we see the we'll categorize the vasomotor symptoms into mild symptoms and moderate symptoms. Basically, what actually happens in menopause, when a woman reaches a menopause, her ovaries stop making the estrogen. So now, because she has a low estrogen, she can have hot flashes, sudden feeling of heat, night sweat, mood swing, poor sleep, vaginal dryness. These are called the vasomotor symptoms. So first of all, we will check that how bad the symptoms are. If they are mild, which means they are just the occasional symptoms, you will try to do the behavioral modification or try the lifestyle changes first before going towards any medical option. But if the symptoms are moderate or severe, which means they occur daily or they are disturbing the work or sleep, then you should consider some medication. If your symptoms are mild, you can simply try the behavioral or lifestyle changes, like you ask the patient to wear light clothes or to sleep in the cool room or to avoid spicy food, caffeine, alcohol, to quit smoking, exercise and lose some extra weight, practice relaxation or breathing techniques. So, if this helps, there is no need for medication. So, these are generally the recommendations or behavioral modifications we ask the patient to do in case of mild symptoms. But if the patient's symptoms are moderate or severe, then we can decide if we can put the patient or women on estrogen or not. Because if the symptoms are severe, then we have to start some medical option, and the medical option we have is estrogen. So before starting estrogen, we have to look for contraindication if present or not. For example, if a menopausal woman is having some estrogen contraindication, we can't start the hormonal therapy right away. So first of all, we see that if estrogen is not safe, some women can't take estrogen because it can make certain diseases worse. So the contraindications or unsafe conditions for estrogen are if there is a history of breast cancer or endometrial cancer, if there is a history of heart disease or stroke, if there is a history of blood clots like DVT or pulmonary embolism, if there is a history of liver disease. These are the conditions in which the estrogen is not recommended, or these women should avoid the hormones and go for some non-hormonal therapy options like SSRIs. So, if your patient is having some contraindication to estrogen, you can't start the hormonal therapy. You have to put patient on non-hormonal therapy thing like SSRIs. But if your patient is not having any contraindication, then you will see that um, uterus is intact or not. If the uterus is intact, you can start estrogen and progestin. And if uterus is not present or uterus is not intact, you can put the patient on estrogen only therapy. For the non hormonal medications, we have options like SSRIs or SNRI. It will help to calm down the hot flashes by acting on the brain center. You can give gabapentin, it will reduce the night sweats. You can give clonidine, it is a weak option, but it is used only if nothing else works. So majorly you have SSRIs, SNRIs, and gabapentin that can be given as a non-hormonal therapy options for the menopause treatment. Then we have discussed that if estrogen is safe, you will look at the uterus. If uterus is present, you can give estrogen and progesterone both. But if the uterus is removed already or hysterectomy has been done, then you can give estrogen only. Clear?
Okay.
When you start the hormonal therapy, few things you need to consider clinically. You always start with the lowest effective dose and you try to stop the hormonal therapy within 3 to 5 years. You have to review the patient yearly, and you can also have some transdermal or skin patches option for estrogen that can cause the fewer side effects as compared to oral pills. So it's not like that if you put a patient, a menopausal patient on hormonal therapy, the woman keep on taking the therapy for 10 years or 5 years. You try to stop the hormones within 3 to 5 years. Clear?
Yes, clear.
Okay, so this is it for today. If you have any question, you can ask.
No, I'm good. Thank you.
Thank
No,
you.
Dr. Fatima, please, just a comment. Sorry, still on the book to read from. Like the first aid is great, but the problem I had, and I think that's why I asked you like the first time, is not in the first aid. I don't know why. I think she
I
left
think the
already.
doctor got her
Yeah,
out
she
from
left.
there.
Yeah. I don't know, like, if it's the network or if she's gonna come back. Like, it's always a problem for me because I try to look for like the where she's reading. Like, for example, this is the topic we did today on OSA, right? All the things she was talking about, even the medication, like the modafinil, it's not here. And the thing she was talking
Yeah,
about, like the grading, like 0 to 15 beats, those things are not here. Look, like this is all the topic. This is
Wait,
it.
where did
Just,
Dr. Fatima go?
I don't know where she left. I don't know where she went. She's like, this is it for today. Maybe her network.
Maybe, yeah.
Yeah.
Maybe we can ask in
So
the next class, like you said.
yeah,
yeah.
I mean, I was just showing you guys. So this is it. Like, this is all of it. And all those things she said is not here. Even the medicine, the
Yeah,
different, the chronic, nothing is on here.
I
Yeah,
know. Like
she
even
is
I like
most,
reading textbooks before preparing before any class. I don't like.
Exactly. Yeah. I actually like to read after she finishes just to go back and review, but
Yeah,
nothing is there. Nothing
yeah.
is there.
I know.
Every Even the
more of
cardio.
her content is like from the descriptions after each keyword question, like related to the topic.
Mm.
So if you gathered all the information from your word or like the description about that conditions, you will
Mm-hmm.
see that all the information she mentioned is from there.
Oh, s-
So it's like
so
a question based. She goes,
ah,
yeah, like that.
I wonder if it's an inner circle. I'm just like, so how do we get something like that?
I believe Dr. Fatima has notes of her own, right? Because her PDF, remember for asthma, she's shared a PDF with us.
Right, yeah, that's
Maybe
true.
she has like compiled everything in her PDFs.
Maybe. I
Could
don't know.
be.
I mean, it would be really nice if she could just share that, like, so we can quickly review things. It's so difficult having to watch the videos all over again. I find
Yeah.
that so difficult.
Maybe for the next class, we can ask her. Tomorrow we have class, right?
Yes, she said tomorrow we have class.
Yeah.
Yeah,
Yeah,
Okay.
I don't know if it's
All right.
here. All right, guys, thank you so much. I'll just keep
Kind of
looking.
good.
Mm,
Okay. Bye.
Good night. Bye-bye.
bye bye.